Welcome to episode 1 of the NHS Armed Forces Health Podcast, a series that aims to help you, the Armed Forces community, access the plethora of NHS services available. Who do I mean by the Armed Forces community? Service personnel, veterans, reservists, and their family members. Through these episodes, we will look at different aspects of healthcare, from leaving service to finding a GP, taking care of mental and physical health, and provision for forces families. In today's episode, we are looking at the AFPPV itself, the Armed Forces Patient and Public Voice Group, and the important work that it does. For this, I am joined by Nicky Murdoch, Chair of the AFPPV, Kate Davis, Director of Health and Justice, Armed Forces and Sexual Assault Referral Centres for NHS England, and Tom Fox, Director of Fortify Mental Health Training, and member of the AFPPV.
Hello, everyone. Thank you so much for being here. Why did you get involved in AFPPV? Kate, can I start with you, please?
Well, AFPPV is the Armed Forces Public and Patient Voice Group. And as a director in the NHS, and I suppose my experience of having the job that I have, I fundamentally believe that you can't deliver, fund, commission any of our NHS services without embedded co-production of the patient. And for me, I'm very lucky to be the director leading Armed Forces commissioning. And the simple answer is there is no way that we should be looking at a national commissioning programme, looking at the consistency and the quality that we want for our own families and the Armed Forces community, without having centrally a group that is there to support the patient's voice, and actually to have both serving reservist families and their veterans at the centre of all that we do means that AFPPV really has influence and also can challenge us to make quite sure that we're doing the best we possibly can for our Armed Forces community.
Brilliant. Nicky, can I bring you in now?
Well, I was chief executive of a small defence charity that was delivering a hospital welfare service in NHS hospitals. And I was seeing the journey that patients and their families sort of undertook. And it's in that role that I learned about the NHS and the relationship with the public and patient voice and how important it was. And so I became interested in how the influence could be exercised for the Armed Forces community. And as a veteran myself, I wanted to make sure that we did as much as we could to get the best outcomes for patients and their families, which is clearly the same intent that the NHS have for patients, as Kate's just said. And so working as I was with the charity sector, with the Ministry of Defence, with the Office of Veterans Affairs, and the NHS in England, but also some of the devolved nations, we were looking at the UK Armed Forces community and how we could best achieve the optimum outcomes for patients and their families.
Tom, what about you?
I became aware of the PPV through Nicky, and Nicky said to me during one of our meetings, actually, I'm becoming the chair of the Armed Forces Public Patient Voice Group, and I think you would be good on that group, as a member of that group, and add in some input. I've been experienced of using the services, the NHS services myself, and what that was like for me. And so using that experience
as a veteran,
suffering with mental health illness, and so bringing that experience to the group and having some input into the way the services are structured now, what we can do to get those changed, how we can improve those, and then working with Kate, the commissioning team, etc., and having input with other veterans that perhaps also access the services as well, and giving some guidance to the NHS about how we felt about it and perhaps how things could be changed for the better. Well, I certainly felt that would help other veterans that might be, or Armed Forces community people that would be coming to the NHS and searching for services. It's not always easy to reach out for help. And so anything that I thought that I could do to make it easier for people to reach out for help and for that help to be there and be adequate and fit for service would be a positive and would be well needed.
Some really interesting points there from all of you, and we're going to delve into some of those as we carry on going through. So thank you. We know that the AFPPV stands for the Armed Forces Patient Public Voice, but what actually is it? And how does it fit into the wider context of the NHS?
Well, I guess there's two answers, Alice, that I can give you, because I think it's important to see it from the formal and legal context as well as the actual heart and soul, if you like. So the NHS commissions billions of pounds worth of services across, and I can only talk for England as NHS England. And it is quite rightly the legal requirement that we can't commission our services, we can't create new policies and new services without consultation with the public and with the patient group. And I think people listening to this podcast will probably know things that are quite familiar in things like when someone says they're a friend of a hospital or they're part of a group looking at cancer services and how they're developed, or when there's a new building that's being developed for primary care in a local community, then there may well be a notice about the consultation about is that the right place to put it, etc., etc. So that's how the legal requirement works. So when we, as NHS England, took on the legal responsibility for commissioning in partnership with the Ministry of Defence, with the Department of Health and Social Care, and with the public, Armed Forces Commissioning and Services, it was one, a given legally, but it was actually the second part, completely and utterly a necessity to include the patients, the public, as part of what we were delivering and what we wanted to develop further, and actually say, how do we do it? What's the best way? What does that feel like? How does it actually practically? Because, as NHS managers and commissioners, funders, we can come up with some great ideas. We can continue to deliver services that we've always delivered, but they aren't necessarily always the right thing for very specialist areas of patient pathways or for people. And so the public and patient group, the heart and soul of it, was actually reaching out to men and women who were serving, who were families, and we mustn't forget the families and carers in this, and also who are veterans, to say, would you be part of a national group that sits within the governance of all of the work that we do in commissioning multi-million pound and even billion pound services, to be central, not only as part of a group of men and women who are part of the armed forces community or have been, but also then being members of other boards, other committees, so that when we're doing some very formal work, we also enable Nicky as chair or other members to then be part of other infrastructures and groups, because that's back to the second part, that's the legal part to support and make the most of it. So it's not just a talking shop. It isn't, and thank you very much, that's a really nice conversation, but we'll come back to you when we're ready. It's all about integrating it across the whole system. And I will be, kind of dishonest to say that there haven't been some really challenging moments and really heartfelt, really difficult stories that have come through the patient and public group. The group of people, and Nicky and Tom can talk about this better than me, has been developed over a number of years, and is a small group representing basically 2.6 million veterans and many other hundreds of thousands of armed forces communities, a tall order. So at times it is really important that we are hearing where we're not doing the job properly, where it isn't accessible in Bristol, but it is in Birmingham, and that's not good enough. And then working out together how we can develop and support the services that we need within the NHS, but also maybe new and innovation. And if I'm going to say one thing in conclusion that the Public and Patient Voice has done, it's absolutely driven innovation and difference in a way that I think it needs to be incredibly proud of.
Thanks. That's really clear oversight of what it is. It's driven innovation and difference. Brilliant. So, Nicky, I'm going to bring you in here. To use Kate's words, so who are the heart and soul of the AFPPV?
Well, the heart and soul of the group are people who have lived experience of a range of injuries and illness, and Tom's already alluded to his mental health challenges. I equally have had mental health challenges. I've also been a cancer patient in the NHS. So all of us across the whole of the group have lived experience on which we can draw. And in order to make sure that we're representative, as Kate's mentioned, of the entire armed forces community, we've got members of the Royal Air Force, the Royal Navy, and the Army, because the challenges they face are different. There's lots of common elements as well, but we need to have representation from all three services, and the Royal Navy includes the Royal Marines. But we've also got people who are currently serving in the armed forces. We've got reservists. We've also got veterans like Tom and I. But on top of that, the demands made on the armed forces community place significant demands on the families. And so we have family members that also represent the serving, the reserves and veterans community as an integral part, and they've got lived experience of perhaps children who've got special health needs or special circumstances that need to be taken account of, the mobility of military families. So all of those things are represented in the group. But additionally, because, as Kate's already mentioned, the partnership is so important, we work very closely and have members of the Ministry of Defence on the group in both the People's Directorate, but also the Surgeon General's Department. We've got all three families federations represented, and we've got some charities represented who have specialist expertise that reflects part of the work programme that Kate's team run. So we've got Fighting with Pride, we've got representatives of the Women's Royal Army Corps Association to ensure that the expertise we've got around the table can be drawn on by the NHS Armed Forces team. We have a continual dialogue with both the Armed Forces team and within the group to ensure that we're keeping current, because there's an awful lot of change going on for the NHS at the moment. And it's really important that our group have a good understanding, a robust understanding of two very complex areas in terms of defence and the NHS. And we do that in a range of ways. So Tom, for example, is on the clinical reference group, which is a group that is made up of clinicians who are looking at the clinical elements of the service. And we have advisors, expert advisors like Tom with lived experience who contribute to that particular group. We've also contributed to research when research is being done on, for example, the issues facing ethnic minorities or issues facing women or the LGBT community. We have experts who are able to contribute that lived experience. We've also been asked for our opinion on some issues that need resolution, and we've convened the group together to have really good, strong, robust discussions and to then make a recommendation to Kate and the team. And that's been really empowering, actually, because we have been able to influence it at quite a high level.
And we're going to talk about some of those achievements and influences that the AFPPV has done. But just, I mean, this group sounds incredibly powerful, diverse, hugely representative. And I can imagine if as an armed forces community member, I would feel really reassured that I had a sort of a voice at the table and I was being listened to. But how many people are there? It sounds like there are sort of hundreds.
We have quite a small group of lived experience people on the PPV. So there are 6 independent members. Then we have the organisational representatives. But one of the joys of the armed forces and the camaraderie that it breeds is that we have our own personal networks that we can draw on to gather intelligence, information, experiences across a range of networks. But the joy of the PPV group is that they've undergone some specialist training, which makes them expert advisors in terms of understanding clearly what their role is. So there aren't hundreds of people. It's a discrete group of experts who understand their role within the NHS and then use their own networks to draw on advising and helping to inform the NHS decision making.
Brilliant, thank you. So Tom, now as an AFPPV member, why do you think it manages to drive innovation, make a difference and influence change so effectively?
Building on what Nicky's just said there, we are such a diverse group. We really are. There's a real range of experience, service times. So when people served, where they served, how they served, who they're linked into. A lot of people on the PPV actually have channels, like social media channels, and they're listened to by the armed forces community in lots of different ways. And so getting the message out there about what's going on within the NHS, but also listening to feedback. What do people want? What are people saying? What's the word on the street, if you want? What's the jungle drums doing? We sort of get that beat coming back through to us as well, and that helps us when we're having our meetings on PPV. There's a real desire to drive change and to work with the NHS as a partner. We don't feel as if we're bolted onto the NHS because the NHS have to have a PPV, for instance. We really feel listened to and part of the group, and I think that's really, really good. It's a really good work ethic that we've got.
I suppose just sort of quickly, what are the limiting factors? Because there must be some.
Well, the NHS is a massive organisation. It's huge, and same with any organisation that's huge. Trying to get the message in there. You're not talking about getting the message to 2 or 3 people. You're talking about getting it to, to hundreds of thousands of people within the organisation itself. One of the biggest challenges we come up with, though, I think, is geographical, and we're very lucky that the NHS is doing well. The NHS England is doing what it's doing. Because we're seeing such a massive push. This focus is NHS England. And a lot of people, again, don't realise that we have devolved nations and they have their own NHS services. So one of the things that I hear constantly from veterans, from families that want to access services is, well, this isn't available in my area. I live in Glasgow. I live in Cardiff. And that's a frustration. That really is a frustration, because they will, quite rightly say, well, I served in the British Armed Forces, so I deserve parity of service. If why has so and so in London got this service, or so and so in Yorkshire got this service, but I haven't got it just because of where I live? And that is, when we talk about health inequalities in a minority group, I think that really pinpoints it. It's a massive health inequality because they feel that they've given service to the whole of the nation, but are then limited on any service that they can have in sometimes their real time of need, a time of struggle. And that can be, very, very negative in the way they're feeling about themselves.
Kate, is there anything that you would like to say in response to that?
Just picking up the devolved administration's work. I think one of the things that we do. I was on a major board that's been going for many years called the Armed Forces Partnership Board, which is co-chaired by the Director General of the MOD and the equivalent director within the Department of Health and Social Care. And that actually has a remit to bring together devolved administrations to support and build on good practice. So, I was only listening to what Scotland were doing, and certainly, we visited Scotland, Wales and Northern Ireland, particularly to share good practice both ways. And it may not sometimes be called the same thing, but there may well still be the same systems in devolved administrations. And I think that's where I would pick up Tom's point. It's that frustration about how we communicate some of those things when you're looking it's an interesting concept, isn't it? The one government department that is a UK government department is the Ministry of Defence. And so it has a unique way, and sometimes not always an obvious way, of blending when you're a military personnel and then you become a civilian, or your family is still living in Scotland or in Northern Ireland or in Wales or in England. How do you do that element? So I think that's a really important point, because for the military community that has to be a given. I think actually one of the PPV groups, things PPV did before COVID, and I think they did a roadshow, and there was never a group when we didn't meet in a different part of the country in England. And so we were in Coventry, we're in Birmingham, we were in Brighton, we were in Newcastle, and actually also inviting people from particularly the NHS or other public sector, third sector, independent bodies that were working in York around the armed forces community, or even just working in York around the NHS, and say, come and listen to some of the situations, and making it quite local as well as making it England wide. And that was incredibly powerful. And actually we moved mountains in getting local areas to go, oh my gosh, if that's happening down the road in Doncaster, why don't we have that in York and in Newcastle or wherever? And it's just really not about calling people out, because everyone wants to do the right thing. It's actually also saying quickly, we've learnt lessons in doing it this way. Let us tell you and let's support you how to do that. So, there are lots of things that the PPV group are driving us to do to keep that network, and also to keep our finger very much on the pulse of ensuring that it's there. But my biggest aim, this is an NHS England group. Let's not, kind of beat around the edge on this. It has to be there to influence NHS commissioning and services, and it absolutely has done that, in particularly looking at specialist services and pathways. But one of the things that's probably the hidden hero here with the public and patient voice, in the way that it's been a small group that's reached out, is just everyday mainstream business in the NHS. So it doesn't necessarily have to be a V for Veterans Mental Health Service. It's how it's influenced the generic mental health services or the generic work in hospitals. And that's a powerful element of work that really can, kind of have a lot of influence, but not necessarily get a lot of attention.
The PPV, as you've said earlier, is a legal requirement, so it has to happen. But, from what everyone's been saying, what you've just said there, it could be a box-ticking exercise, but however, the AFPPV clearly isn't. What has it done, and why has it been so effective?
Well, I think the first thing it did when it set up is it looked at the services and the funding that we were prioritising to develop and commission as part of our formal plan for armed forces commissioning. And it helped very much in analysing and supporting the quality and the practical agenda of how that would work for a man, woman, girl, child, boy, family, looking at and saying, that is there for me. The first thing that the PPV group did was challenge us, saying, that's great, Kate, but that really doesn't say that's there for me as part of an armed forces community or a veterans community. This has got to be looked at in communication, in engagement, in the personal touch. That was our first challenge, and pretty tough one, if I'm honest with you, to start with, because I think it did pull us up to say, we weren't necessarily doing a full range of provision, particularly for the veterans community and families and carers. And the way that we were working, and still are very appropriately and very well, with the Ministry of Defence, but actually this is about a broader agenda for serving personnel and reservists. And one of the first things we did also for serving personnel and reservists was look down a long list of where was the interface with military community, employment, housing, different access points on transition. what was the whole philosophy that we were working together on mental wellness. The other elements that are probably quite well known is then being part of co-production and modelling our big programme of work around mental health services for veterans and families, which is launched by Sir Simon Stevens, who was the Chief Executive of NHS England, Sir Simon Wesley, myself, but most importantly, a number of men and women who are veterans, Op Courage. And Operation or Op Courage is the name that oversees 3 distinct areas of the way that we access and support veterans and families around mental health needs. And actually, it's a small thing, but it's a major thing. When we were developing the mental health services and alongside the PPV group around transition and intervention and liaison access before leaving service, but actually, even if you've left service 20 years ago, how do you really know it's there for you in Brighton, Blackpool, or wherever? Then there was a real moment from the PPV group saying, look, this is great. We're getting a lot of people front door, but actually the real complexity of combat-related mental health is still not being addressed. So we then, because of the PPV influence, then looked at the second element of that development over the last few years, which is called the complex treatment service, which was very much about a real wraparound intensive mental health service for combat-related mental health and trauma. And that was a groundbreaking moment that isn't actually talked about very much, because that would not have happened without the public and patient voice saying, this still isn't hitting the mark. And then lastly, but still this is developing, is the high intensity service within Operation Courage, which is there to support 24/7 crisis care, particularly looking at suicide prevention, harm reduction, but again, real immediacy as well. And that's our newest element of Operation Courage. And in fact, the PPV group and the peer element of that is the model of the service that we deliver. So it isn't commissioned without elements of peer support as part of that service. And all of those services now aren't commissioned without collaboration with the Armed Forces charitable sector. Again, another influence from the public and patient voice. And the name, Operation Courage, was selected, debated, consulted on by the public and patient voice group. And as Nicky says, from looking at other broader networks, because we had a range of names that weren't necessarily appropriate or understood. And Operation Courage came along, and that's what the patient voice said, that's what it needed to be, and that's what it is. So that's just an example. But I think the family voice is probably one of the areas that is very clearly been influenced. We ran a major consultation. We've done a few from the public and patient voice with over 1,200 family and carer members, saying, what does this feel like for you, both serving and reservist and also as veteran? And I'm really pleased to say, as part of this podcast, and I'm probably the first person to say it actually on the podcast, Nicky, you'll be really pleased with this, and Tom, that we're about to fund, alongside the new integrated care boards, integrated care partnerships that are developing with the new health and care bill across all 42 integrated care boards and partnerships, a network of family and carer armed forces services. That will take time to develop and devolve, because we'll be working with the PPV group and the family and carer section to say, how will that work? But we've actually identified the funding for an England-wide family and carer network. It would not have happened without the public and patient voice challenging us constantly on that, and then delivering a formula. That sounds quite NHS manager speak, doesn't it? But a kind of something that made sense to people. I mean, it isn't just the big things; it's just the small, important challenges that come across on an email, that come across on a voicemail, that come across in a small working group. That doesn't make sense when you're filling in that form as part of your prosthetics renewal. How do we do that, and how do we get that better branded for Black and minority and Asian men and women? What does that mean when we're looking at something that's really important alongside, I'm not a military person. My background is varied. within the NHS and beyond. But what we do is we come together and we work it out.
I think one of the most important things that we need to accept as a network in the armed forces community is that there is a huge amount of work going on, and that I alluded to it earlier, that the armed forces community can be quite vocal and it can be quite critical. And I think one of the roles and functions that the PPV group has, and has done pretty successfully, is to get accurate information out to our networks about the great work that is being done. And nobody's saying it's perfect, but actually, I think our voice is being heard, we're able to influence, and I think in ensuring that the community understands that and believes it has actually led to a change in the narrative about the NHS supporting the armed forces community. And I think I would observe over the last 5 years that narrative has changed. It doesn't stop observations being made, but what it has done, I think, is it's made the NHS be seen as the key provider for healthcare, and not necessarily the military charity sector, but the military charity sector working with the NHS in collaboration and partnership optimises everybody's resources, and that leads to better outcomes. And I think that has led to a change in the narrative and a change of approach in all of us about working together to get the best outcomes for patients and their families from our community. But it spreads beyond that because it influences the NHS as a whole, in a way that the surgery in the battlefield has led to improvements in prosthetics, not just for the armed forces community, but for everybody in the NHS who needs a prosthetic. So the improvements in a small population like the armed forces has significant benefits beyond, which again has got to be a good thing.
Having that lived experience must be therefore fundamental to the success and that you have achieved as at the AFPPV.
Although we have the PPV group for NHS Armed Forces, there are PPV groups and public patient voice groups in primary care practices and all the way through the NHS. But the lived experience is vital because people can draw on that lived experience. It gives it an in-depth understanding of what a patient goes through, and unless you've been through that, it's quite difficult to imagine it. And I think that the trick for the PPV group is to ensure that you can draw on that experience without generalizing and saying, well, this was my experience and it was really bad and therefore everything's bad. It's being able to identify what would make it better and identifying those particular issues that don't go quite right, and knowing that it's not an individual incident, but actually these are things that could be improved for the whole service. And things like maternity services care for serving personnel who use the NHS services because that's what they have to do. But taking into account things like mobility and deployments, those are the sorts of things that we need to draw on to make sure that the maternity care pathway is fit for making demands, physical demands on individuals, as you do in the armed forces community. One of the major issues is musculoskeletal injury and impact. And so in designing services and making sure they're fit for purpose, one needs to, talk to somebody who's going through that particular experience. And that means getting better outcomes for the patients and their families, because wherever there's an illness or injury, there's a knock-on effect to families. And And actually, and I sort of touched on it earlier, but that makes it better for the NHS, not just for the armed forces community, but every patient. And it will drive improvement across the NHS as a whole, increasing effectiveness of the service, which is why the lived experience is so important. And I think the other element, and again, this is about the partnership with the military charity sector, but in terms of resource, the military charity sector is very lucky. And optimizing accessibility to that resource by working closely in partnership means that you get better outcomes, but you're also making sure that you're using resource, and sometimes that can speed up things like delayed transfer of care, because the Royal British Legion can provide adaptations for housing perhaps quicker than local government. So using those resources, you can actually move patients through the pathway a bit quicker, which helps the NHS. And again, that's the sort of partnership that is really effective.
So effective partnerships are absolutely key. And also, I just want to bring Tom in here, and just going back to the lived experience answer from Nicky. I know that you've had your own challenges accessing services. How have your experiences helped you to influence change that the AFPPV have achieved?
I think based on my own experiences, it set a benchmark for me, really, that I didn't want to see it. I didn't want to see other people suffer when they were accessing services at their lowest ebb. I didn't want other people then to go through perhaps the same sort of experience that I had, which wasn't positive. And so I set that as a benchmark. Really, that's got to be like, can't get any worse than that. What can we do about it? And so it's been working to build on from that. And when I do listen to people say, well, actually, this service isn't very good, or because people often base their assumption of the whole service on their experience, isn't it? And so talking to them, and I say, actually, look, I understand you had a bad service, but do you know what? So did I. But guess what we're doing now? Guess what's there now? Guess what's available now? Do you know about this? Do you know about that? So it's being able to take that experience of what bad looks like, potentially, and knowing now what's happened. I can see how far the services have come. I can see how different it is now to maybe 5 years ago, 6 years ago. I can see how much the NHS, and like I said, it's a big old institution. The NHS, big old organisation, and same with any big old organisation, it takes a long time for things to change and to turn around. And I'm absolutely over the moon with how quickly the NHS have actually got new services online and actually work to make sure these services are there. Because let's face it, at the end of the day, we're not talking. The service is important, but the person is much more important than anything else. It's all about what happens to that person that's perhaps in need and is reaching out for help. Do they get it? Can they just pick the phone up and talk to someone? Can they talk to someone that understands them, will listen to them, and actually work out who they are and what services are available for them, and then plug them into the right services? So what's their journey like? From accessing services all the way through to treatment and beyond, that's what we're looking at all the time. It's about the person. I mean, someone said to me a long time ago, I'm not a doctor, obviously, but someone said to me, a good doctor treats a disease, a great doctor treats the person. A couple of things coming from that as well. As I said, charity sector do a huge amount of good, and they have been affected by their income dropping. But this is also where the PPV and the influence with the NHS and working with the NHS and working with the charities. This is where this is so good, because the NHS fund a lot of these great services that the charities provide, and so I think that and that's key. If the service is provided by XYZ charity, the NHS will actually say, we'll partner with them, then we'll provide funding for that, and we'll work them with it. And so that's so important, because that charity may have not been able to provide that service anymore. So we've got to always think about that. What is the NHS doing? It's funding these services and keeping them afloat in some instances, and keeping them going and building on that so they can have a greater level of excellence than they did before even. So there's so much good coming out of it. What I'd like to see as well is, this is NHS England. This is how good can look, and working with other, third party, third sector, the charity, etc. Let's say that someone accesses NHS services, a veteran, a family member accesses NHS services. It becomes apparent that person also needs help with other areas of their life, maybe financial, housing, etc. the NHS service will signpost out. Unfortunately, one of the things that means is that they're probably going to be talking to a charity. So I hope that what we're doing with NHS actually helps to drive change within other government organisations such as DWP, who really need to be also thinking about what they can do to support. So I think we could look at what we're doing, and I think this sounds a bit big-headed, but I think we can look at what we're doing as a model for good, positive change and how things need to be and what working with each other can actually look like. And so that expands out to other departments.
I think for any listener, any service user, I hope they feel really reassured by what they're hearing. I just want to leave everyone with some thoughts from all of you. So I'm going to ask you to go 3 questions. Anyone can answer them. So just jump in any order. The first one is, what are you most proud of having achieved?
I think I'll start with that, if I may, Alice. I think from my perspective, I think developing a group of people who are experts as patients, but also with a very good understanding of the NHS services that are commissioned by the Armed Forces team, and are able, based on their knowledge and experience, to influence and deliver with the Armed Forces team an improved service or a new service is absolutely the thing that I'm most proud of.
Kate, how about you?
What I'm most proud of is that we're now, without a shadow of a doubt, a team. We're an Armed Forces, NHS England, central and national team, which is essentially made up of lived experience, men and women, and it will never be anything else but. And if you have that as the model, then we can carry on taking on the challenges, but also building. I think one of the things that I would just sort of say personally, it's actually about hearing that it has made an amazing difference to people. And the number of people I've said, oh God, I wish that service had been there a few years ago. And it really is important, is actually the barometer, I think, that I'm most proud of, that that has definitely had an impact and made a difference. One of my Armed Forces services, they're not on the PPV group, they're someone I met recently who did a most amazing and emotive speech about their personal situation and their services, both in the veterans community and the charitable, but the NHS, and said what was really helpful is people stopped asking me what is the matter with me and asked me what matters to me as a serving person or as a veteran. And I thought, wow, what a really lovely, powerful line. And that's really made me very proud.
Wow, that's amazing.
Yeah, I think, it's easy, or it could be easy for the veteran community and families and reservists to sort of think, well, the people in there making decisions are, NHS employees or MOD employees or whatever, and they're disassociated from us and they're just making decisions about things and spending budget and putting a service in place. It's important to understand that's not the case. It's important to them to feel that they have a voice in this, and that the people that are working with the people that have the budgets, that are putting the services together or providing the treatments, are veterans themselves. People have had that lived experience, and that we are working to ensure that the NHS understands, as Kate was saying there, who's the person, what do they want. That's so important, and that they understand that it is people like them that are working to get these services online and available to them, so that when they access the service, they get a service that's excellent for them. And it's excellent for them because someone further down the line one day said, you know what, this service isn't so great. It'd be great if you could tweak it in this way for us. And that's really what it comes down to, I think.
Thank you. Brilliantly put.
I think it's about giving the Armed Forces community confidence that their voice is being heard and it's being understood by the people designing the services. And I think that's the journey, to use that hackneyed phrase these days, that we've been on. And Kate's empowered us, the team have empowered us to share that experience and improve services, and that's the nub of the issue, really.
And I think that actually is the perfect point to finish on. So thank you very much. So thank you to all my guests, Nicky, Kate and Tom, and to you for listening. Over the next few weeks, we're going to be covering medical provision in and out of service, the process of leaving, your relationship with your GP, physical and mental health, and provision for armed forces families, with each of our episodes featuring a mix of experts, service users, and those responsible for influencing change. In episode 2, we will be looking at medical provision in active service, as well as negotiating leaving the military and accessing services outside. We hope you will join us. Goodbye.